Hello friends, greeting from Rfatutors, your mentor this side with the Green Top Guideline of the day. Today we are here to discuss about the chickenpox and pregnancy, the Green Top Guideline number 13, published in January 2015. It is a DNA virus transmitted by fomites, respiratory droplets, and during significant contact, same room, 15 minutes or more, face-to-face 5 minutes, and contact in the sitting of a large open ward. Incubation period is 10 to 21 days, infectious 48 hours before the rash until vesicles they crust over. Remains dormant in ganglia and may be reactivated as herpes zoster. Primary chickenpox infection approximately 3 in 1,000 pregnancies. Over 90% of the populations are seropositive for varicella zoster immunoglobulin IgG. 25 deaths per year approximately in United Kingdom. 75% of them are adults. All these figures are very important for your exam. Varicella vaccination pre-pregnancy or postpartum is an option that should be considered for women who are found to be seronegative for varicella zoster virus immunoglobulin. While universal serological antenatal testing is not recommended in UK, seronegative women identified in pregnancy could be offered postpartum immunization. Women who are vaccinated postpartum can be reassured that it is safe to breastfeed, an important single best answer. Women booking for antenatal care should be asked about previous chickenpox, shingles infection. Women who have not had chickenpox or are known to be seronegative for chickenpox should be advised to avoid contact with chickenpox and shingles during pregnancy and to inform healthcare workers of a potential exposure without delay. When contact occurs with chickenpox or shingles, a careful history must be taken to confirm the significance of the contact and the susceptibility of the patient. Pregnant women with an uncertain or no previous history of chickenpox or who comes from tropical or subtropical countries who have been exposed to infection should have a blood test to determine varicella zoster virus immunity or non-immunity. A pregnant woman who develops a chickenpox rash should be isolated from other pregnant women when she attends a general practice surgery or a hospital for assessment. If the pregnant woman is not immune to varicella zoster virus and she has had a significant exposure, she should be offered varicella zoster immunoglobulin as soon as possible. Varicella zoster immunoglobulin is effective when given up to 10 days after contact. In the case of continuous exposure, this is defined as 10 days from the appearance of the rash in the index case. Non-immune pregnant women who have been exposed to chickenpox should be managed at potentially infectious from 8 to 28 days after exposure if they receive the varicella zoster immunoglobulin, and from 8 to 21 days after exposure if they did not receive varicella zoster immunoglobulin. This comes for the exam all. The single best answers and the practice books extended match question. You can see this question as well. When supplies are limited, issues to the pregnant women may be restricted and clinicians are advised to establish the availability of varicella zoster immunoglobulin before offering it to the pregnant women. Women who have had exposure to chickenpox or shingles, regardless of whether or not they have received varicella zoster immunoglobulin, should be asked to notify their doctors or midwife early if a rash develops. A second dose of varicella zoster immunoglobulin may be required if a further exposure is reported and 3 weeks have elapsed since the last dose. The pregnant woman who develops chickenpox. The clinicians should be aware of increased morbidity associated with varicella infection in adults, including pneumonia, hepatitis, and encephalitis. Rarely, it may result in death. Pregnant women who develop a chickenpox rash should immediately contact their general practitioner. Women should avoid contact with potentially susceptible individuals, example, other pregnant women and neonates, until the lesions have crusted over. This is usually about 5 days after the onset of the rash. Symptomatic treatment and hygiene is advised to prevent secondary bacterial infection of the lesions. Oral acyclovir should be prescribed for pregnant women with chickenpox if they present within 24 hours of the onset of the rash and if they are 20 plus 0 weeks of gestation or beyond. Use of acyclovir before 20 weeks should also be considered. Acyclovir is not licensed for use in pregnancy, and the risks and benefits of its use should be discussed with the women. Intravenous acyclovir should be given to all pregnant women with severe chickenpox. Varicella zoster immunoglobulin has no therapeutic benefit once chickenpox has developed and should therefore not be used in pregnant women who have developed a chickenpox rash. The pregnant woman with chickenpox should be asked to contact her doctor immediately if she develops respiratory symptoms or other deterioration in her condition. Women who develop the symptoms or signs of severe chickenpox should be referred immediately to hospital. Women hospitalized with varicella should be nursed in isolation from babies, potentially susceptible pregnant women, or non-immune staff. A hospital assessment should be considered in a woman at high risk of severe or complicated chickenpox, even in the absence of concerning symptoms or signs. This assessment needs to take place in an area where she will not come into contact with other pregnant women. Appropriate treatment should be decided in consultation with a multidisciplinary team that includes an obstetrician or fetal medicine specialist, a virologist, and a neonatologist. The timing and mode of delivery of the pregnant women with chickenpox must be individualized. When epidural or spinal anesthesia is undertaken in women with chickenpox, a site free of cutaneous lesion should be chosen for needle placement. Women should be advised that the risk of spontaneous miscarriage does not appear to be increased if chickenpox occur in the first trimester. If the pregnant woman develops varicella or shows serological conversion in the first 28 weeks of pregnancy, she has a small risk of fetal varicella syndrome and she should be informed of the implications. Women who develop chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after infection for discussion and detailed ultrasound examination. Given that amniocentesis has a strong negative predictive value but a poor positive predictive value in detecting fetal damage and cannot be detected by non-invasive methods, women who develop varicella infection during pregnancy should be counseled about the risk versus benefit of amniocentesis to detect varicella DNA by polymerase chain reaction. Amniocentesis should not be performed before the skin lesions have completely healed. If maternal infection occurs in the last 4 weeks of a woman's pregnancy, there is a significant risk of varicella infection of the newborn. A planned delivery should normally be avoided for at least 7 days after the onset of maternal rash to allow for the passive transfer of antibodies from mother to child, provided that continuing the pregnancy does not pose any additional risk to the mother or baby. A neonatologist should be informed of the birth of all babies born to women who have developed chickenpox at any gestation during pregnancy. Women with chickenpox should be breastfed if they wish to and are well enough to do so. Appendix 1, the algorithm for the management of varicella zoster contact in pregnancy, friends, a very important single-based answer. Some important exam points from this green top guideline are the IVIG use indications, when to choose the acyclovir oral or intravenous, what is the management of chickenpox in a stepwise manner. Best of luck from entire team of Rfatutors. I thank you for joining us today. See you next time, and until we meet again, take very good care of yourself. Bye-bye.